I think these are the five queries that we must keep in mind as we go forward. How should small hospitals respond? Hospitals that are about 100 beds. How should large hospitals respond? 1,000 beds, 800 beds, 1,500 beds, private and public. How do we respond without perishing? In the process of responding to this huge need, will this empowerish our own system is a very important question, because that will be self-defeating. And also, how can we plan ahead, for the immediate, intermediate, and the long-term future? So, let's start with the infrastructure first. Obviously, for the acute emergent problem, we can't build anything new, and therefore we have to modify the existing infrastructure. And that's a huge architectural topic in itself. I'm not going into that, but lay out just the principles. There are four other ways to respond. For the intermediate need, we have to think, as some countries have, makeshift field hospitals which have served the purpose very well. I'll detail that in a minute. We also have a few hospitals that have tried creating new infrastructure or tweaking an existing construction process quickly towards the acute need. And then, of course, there's this large segment of home care, which takes care of a large segment of COVID problems like quarantining, isolation. Patients who really do not need to come to hospitals, the home care front is dealing with them very well. And then there is this telehealth or telemedicine or online medicine, which is emerging in a very good way. So these are all the principles which I have picked up from various experiences worldwide. The experience from the US is this, that one must increase capacity by 30% if you really want to cater to the acute need. Which means either we add on 30% extra beds, 100 beds become 130, or you must demarcate 30% of your existing beds exclusively for the COVID pandemic purpose. Okay. It should be in an area that can be segregated, and it's very important to establish a unidirectional entry and exit. Most of our hospitals have got multiple entries and multiple exits. That's been part of our architectural culture. But in a COVID pandemic situation, it's important to shut down or close down all the entries and exits and allow an exclusive entry for those who've got fever or symptoms that are because of the COVID infection. It should be a one-way entry, one-way exit in order to not to mix up the two streams of people. Preferably, it should be in a dedicated area and secluded. And if possible, there must be a temporary externalized triaging system, because the people come, it's like a funnel with no control. It's good to shift the triaging layer of hospital care outside so that you can somehow regulate people who are coming in, segregate them at entry so that they don't mix and cross-infect one another. Several hospitals have quickly converted single to double rooms to maximize capacity, and they have also done, which obviously makes good logic, postpone the elective cold cases. The thyroid nodule or the lipoma on the arm, or things like that can be postponed without major problems. It is recommended that in an extreme situation, places like the cath lab, lobbies, waiting halls can be converted, and sometimes this has been done in large hospitals with the dengue fever crisis, and when there is a large caseload of a particular epidemic, meeting halls and lobbies have been converted. So this is an extreme situation which can augment the capacity of a hospital. What are the advantages of doing this? One is that it's very rapid and immediate. It just takes the civil engineering team or the hospital management team to tweak it quickly using temporary material, rapid and immediate. The capital expenditure on tweaking this infrastructure is not too much, can be borne without too much of financial struggle. The facility that comes up is a familiar ground in terms of exits, entries for the staff who are going to ultimately cater to these patients. And the logistics of material and manpower is easy because you're refurbishing this in the existing hospital infrastructure. Uh, there are a few downsides of this, as many hospitals have experienced. There is a collateral loss of existing patient load because of stigma, because of scare, and because of you have taken away a chunk of regular hospital care patients towards the COVID patients, so which results in a revenue loss and a facility loss. It's an opportunity cost loss. There may also be manpower attrition if there is a COVID infection which has run amok and it has infected the healthcare. It has happened in big institutions in India. There is going to be a post-event stigma which will linger for some time. A hospital which has a few deaths because of COVID or is known to have given care to COVID patients, in the public mind, the lay mind, there will be a hesitation to visit these hospitals and take care, which will result in a revenue deficit. We also know how the press behaves. It's likely to create negative publicity, any adverse event, and that also lingers in the minds of the public for some time to come. So these are all the downsides of using existing infrastructure. This is important, and I'm convinced that this is the way forward, especially for the intermediate solutions, to do makeshift field hospital infrastructure using portable materials such as canvas, tent material, MDF. There are many materials which the architects know. It can be quickly assembled, quickly dismantled. The design is flexible, it is expandable. You can just keep on adding units to the basic structure that you've created depending on the need in both directions. It allows choice of a suitable location. It's preferable to locate the makeshift hospital in an area which is outside the dense locality, especially in urban areas. The advantage is, as we understand this, the Israeli expertise, which was shown very well during the Nepal earthquake crisis, the Philippines tornado crisis, is an example to follow. Closer home in Chennai Trade Center in the city of Chennai, the IIT as well as Anna University has supervised or created a makeshift field hospital, which is excellent. The South Koreans have very successfully managed their crisis with this makeshift hospitals. So these are intermediate solutions, can't be done in a day, but it can be done in 3 weeks, 2 weeks, 6 weeks, if we feel that the COVID problem that we are facing is going to last that long. And the collateral damage is minimal in this area. Just some pictures to show you how the makeshift hospitals look. It's very simple, large space, and it can be remodeled according to our design. So this is the Chennai Trade Center model, which I'm not sure whether it's functional, but you can see that a large number of patients can be accommodated. This is a picture from South Korea where they used ship containers, modified and refurbished to their need. So as I mentioned, these are intermediate solutions. They of course need some permission from the government, which the government is always very happy to help in emergencies like this. There are minimal risks to the healthcare, and it becomes a common facility for multiple hospital groups to put their inputs into. This is a big advantage. Rather than struggle in 10 hospitals in a big city, personnel from all 10 hospitals, the expertise from all 10 hospitals can congregate in these common makeshift hubs and deliver excellent care, I believe. It safeguards some other hospitals because it protects the assets as well as the facilities from unregulated infection by the problem that we are dealing with. It's easy to seclude, quarantine, isolate, manage. We already have a few proven track record of this model. So I would urge
Professor,
that,
sorry, Professor.
as the epidemiologists tell us, this is a picture of a makeshift hospital in the city of Chennai, done at the Chennai Trade Center. This, I'm not sure whether this is functional, but this has been done by IIT as well as other university. This is another model which has used ship containers, very quickly refurbished and put to good use by the South Koreans, and they seem to have managed the crisis pretty well. So these makeshift field hospitals are ideal intermediate solutions. We need a little bit of governmental collaboration with that, which is forthcoming in a crisis situation like we're facing now. It minimizes the risk to healthcare personnel because the environment far away from these mother hospitals where we can do a collaborative
Uh,
caregiving.
Hello.
Yes.
We just lost you for a second, so if you can just last 20 seconds.
Okay. Are you okay now?
Yeah.
Okay. So I was saying this, the slide is visible. I was saying that it becomes a common hub for expertise from multiple hospitals to reach this field hospital, including referring their patients who may have come there. Therefore, it safeguards the mother hospitals from, possibility of close down or lockdowns because there is a spill of the infection, especially amongst the healthcare personnel. So, which brings me to this. I hope nobody is, slide is only being put to emphasize that this is not the pathway to be taken in an emergency. Creating new infrastructure is not prudent to deal with an acute crisis because it is time consuming. You have to get the constructors, the architects, and the logistic people involved. It is expensive, and we don't have enough of financial reserves anywhere. The logistics are difficult. It is not cost effective because by the time your new infrastructure comes up, the event may be over. And after the event, what you created for the event will be absolutely dysfunctional and it will disfigure your premises. Of course, there's an exception. The Naishan Shan Hospital, which was made in Wuhan, was a completely, what do you call, a phenomenal construction of 1,000 beds in 10 days. They raised a multi-storied hospital which came up in no time, and I believe they are dismantling it. Obviously, it is on a prefab construction design. China was able to do it, but I'm not sure whether we are here to do that in our country. However, creating a new infrastructure is a new area of thinking because these kind of pandemics and epidemics are going to hit us even in the future. Therefore, the hospital construction and the hospital planning industry must seriously think of new infrastructure with the insights and inputs that this pandemic is giving us. Tweaking old infrastructure is almost similar to what the Indonesians have done. They tweaked Asian Games Village into a hospital with 4,000 beds. I'll show you a picture of that. There are disadvantages like it's not flexible in location, in size, and transport, and you will still have to deal with regulatory concerns, especially with the disposal of medical wastes that may accumulate over this period of time. And it's not really cheap to tweak whole infrastructure as we have all learned. This is a picture of the Asian Games village in Jakarta, which has got multiple towers. They classified they made it into a COVID hospital and used their different towers for different purposes. Good model if such a type of infrastructure is available.